Welcome to everyone who has joined today. This is our fourth State of the ICUs in California meeting, hosted by the California Thoracic Society. And really, this is all of your forum. We try to bring things to the forefront that's timely, controversial, things to help each other out through this communication forum, because when you're in the thick of things with surge, you want to be able to share your thoughts outside of your own hospital or institution. So welcome everyone. My name is Asha Devereaux, and I'm a past president of CTS and chair of the Clinical Practice Committee for the California Thoracic Society. And the purpose before I go into everything, I'd like to thank Fisher Paykel, SmartVest, and the folks who make Voxen for contributing to this event. This is a non-CME event. They all thought we were just doing the right thing by trying to stay out of crisis mode. And the California Thoracic Society is honored to be able to be doing this. Every week, I keep this image here on our agenda to just show that we are a small part of a big effort when we're talking about surge and overflow and crisis. And right now, what we're doing as a group with CTS is sharing information regarding hospital care. But when all of this comes together, we can all avoid getting into crisis situations, as Dr. Morris earlier had mentioned, and that many people were planning for and thinking about. So that's why we all started this. Dr. Dennis Amundson and Dr. Christian Sandrock and I have been talking about this for the last 15 years. And so they will be the moderators of this evening. And we're honored that Dr. Tim Morris and Dr. Victor Tapson could join us in talking about anticoagulation in a few minutes. And then if time permits, we'll have Dr. Sandrock discuss some more about questions that he has for the rest of the state on what's going on regarding some therapeutics. I'd like to, before we get into the meat of the agenda, share with you something that for many of you who may have been on the first call where we were talking about running out of oxygen. And it was on this forum on January 8th, Dr. Sandrock had said, hey, we need to do oxygen conservation rounds. And we had already been talking about this at the alternate care sites in that I've been a part of through CalMat. And we have been really thirsty for some type of visual guidance in those settings. And that has led to conversations with the Task Force for Mass Critical Care. And rapidly they jumped on this, and the train left our station, and this infographic draft has been created. So I thank all of you on this call, and you probably will see this coming through in your emails soon. So this forum does result in some action too. So with that, I'd like to introduce Dr. Dennis Amundson, who's an intensivist at Scripps Chula Vista, and Dr. Christian Sandrock, who's an intensivist infectious disease specialist at UC Davis, to do the round robin for the state. Thank you. And now I'll mute.
All right, do you want to go start down south, Denny, again as last week?
Yeah, I can't wait to hear what's happening up north, though. So I'll just get through mine, and then I want to listen to you. So we're guarding the border. Zip code 92154 is doing a good job of keeping the border safe, I think. So we're still seeing it rocking and rolling down in Chula Vista. Right now, from a big picture standpoint, San Diego County's had about 2,330 some odd cases, and about getting close to 10,000 have been hospitalized, and about 1,400 being in the ICU. I think I mirror what Christian, though, is right now we're kind of seeing a little more non-COVID that are showing up in the ICUs. The script system, which I've told you before, is a 5-hospital system, has about 394 in the hospital, 119 in the ICUs, 87 of them are on vents and 9 are on ECMO. We're still using non-licensed capacity in South Bay. We're about 118% of ICU capacity. So some unlicensed beds and non-conventional spaces are still being used in some of the current things. Our Chula Vista hospital on the border it's licensed 24 beds. We were running 28, 29, 30, up to 32 at one time, but not for very long. Right now we're sitting at 22 patients. 18 are COVID and all 18 are ventilated. And thank goodness we still are able, at least down south, I don't know about you, Christian, but we're able to move people north still. So our sister hospitals both in La Jolla and Hillcrest and above have been able to take some of our overflows, both from the emergency room and from the ICU. So it's been able to decompress. We remain purple here, though, so I can still get a haircut though today. All right, what's going on up north?
Well, I may be able to get a haircut, but I'm refusing. That's my rebellion against authority. Up at Davis, we're always sort of a little bit of a different anomaly here. Our surrounding hospitals quite aren't as bad at, but I know last week we had talked, and most of our ICU patients that are COVID patients, a good chunk of them have come off of isolation. They've been here so long. We have a number of people well over 45 days on mechanical ventilation. That number has only changed by 2 since our last call last week. But unfortunately, we've had a big surge in non-COVID patients. And I mentioned, a lot of drug overdoses, methamphetamines mostly, alcohol withdrawal, some suicide attempts, a number of gunshots and others. So we actually had to go on diversion for the better portion of the day today, which, we do sometimes, but when it's this level, it's a bit difficult because we have nowhere to put anybody. So we're kind of working on decompressing the ED because all of our ICU and floor beds are full. So we're reevaluating whether we need to expand outwards from there and activate some other layers of our surge plan. So, and again, this is interestingly enough, it's mostly non-COVID. So of all the 8 admissions I took after 2 a.m. that I rounded on this morning, not a single one actually had COVID. So it's just a flurry of other things. Our surrounding hospitals, and again, I can only speak downwards towards Fairfield. I don't know if anybody is from the Bay Area and they want to give some data, that would be great. But they're at least on the state website. And from our Mohawk, there's some capacity in the Bay Area. Our surrounding hospitals here in Sacramento and up towards Lake Tahoe have a little bit of capacity. Most of the EDs are open and not on diversion. So as a whole, I think in Northern California, we're getting better. Davis is a little bit of an anomaly. And unfortunately, I can't send anyone anywhere. I would like to, but unfortunately, the places we usually send them are not the places we want to send them to. So that's mainly it. I will say we don't, there have been, as you've heard, mostly in many of the counties in Northern California, an issue with more capacity. So that is happening. And as I suspect it's happened with you down south. So we've, fired up refrigerated trucks and everything else. So that's the only other issue, but not from a critical care standpoint, just more from a family management standpoint. But, trucking along, but, again, bursting at the seams, and hopefully we haven't busted fully today.
I don't know. I thought maybe there were some people from the LA area on the call. Is anybody have anything from Fresno on down?
Yeah, I thought a few from Fresno were coming. That's true.
Yeah.
Hi, this is George Show at Cedars. Can you guys hear me?
Yeah.
Perfect. Great,
Yeah.
George.
So at Cedars, we peaked at around 310 patients, our census, both combined ICU and non-ICU. We're down to less than 200 now. And our ICU census, though, remains relatively stable at 77, because the ICU patients stay so long in the ICU that even though the overall census in the hospital is coming down, the ICU census seems to remain pretty stagnant. But it's slowly getting better, and we're not feeling as pressured as we were when we had over 300 patients in the hospital at this point. We're still over capacity at about 120%. So we're using non-licensed beds also for ICU, including our PACUs, which is making it difficult on our elective surgeries that we're still trying to do. if they're related to an oncology diagnosis or some other life-threatening problem. But so the hospital is still very busy with a consistent census over 900 patients.
Yeah, still pretty busy. That sounds kind of similar to us up here in Sacramento. So Lori, sounds like we have at least somebody from UCSF so we can get a good sense of the Bay Area and the peninsula a little bit, I hope.
Yeah,
So,
I can jump in. So currently at UCSF Health, which is our across our hospitals, we're down to about 52 to 54 patients in the hospital total, 14 vented, 1 on ECMO. Our surge status has bumped down to the orange level. I would say across over at our ZSFG, or San Francisco General County Hospital, they have 42 patients. Also, kind of what we consider our orange surge status, down from higher levels. Our case, I would just say the asymptomatic case positivity rate has dropped down to 2%, and our symptomatic case positivity is about 9.6%, both of which are kind of down.
Wow. Yeah.
Oh, and I'll add one other thing. And we had a patient who was transferred from Davis that just got transplanted this week for it was he was positive in what was it, August 1st.
Yep,
So just got transplanted.
Oh, that's good news. I actually know who that is. Great family, actually. Great family.
Yeah.
I was really happy to hear he went down there because that was one of our only options left. He was a good man. So, that's good news.
It looks like we've got Tisha Wang from UCLA, followed by Laren from Loma Linda and Vipul from Fresno. So we've got.
Oh, awesome. Some good updates.
Yeah, so this is Tisha from UCLA. So we didn't get quite as busy at Cedars, but we did max out over 200, and about a third of those were ICU patients. We have sort of turned the corner and gotten down to the 120 range. But again, just like other places, we haven't felt the relief in the ICU yet. And actually the non-COVID population has come back quite strong. So, I would say that this is the absolute worst surge we've had by far in the last 3 weeks. We are a hospital system that has 5 24-bed adult ICUs. And we basically were in the PACU and actually had to open up a ward that became an ICU. So it was actually very, very challenging for us. We had 5 ICU surge teams, et cetera, et cetera. We have a small community hospital that has 22 beds that has been diverting to Reagan, which is our main hospital for the last, actually since Christmas. So with all that said, we're not as impacted as some of the smaller community hospitals in LA, where a lot of people that I trained run the ICUs. And so we've actually been able to send some faculty out there to help some of these other hospitals, because I do have a very large faculty. So anyway, so hopefully we're turning the corner. Things are definitely looking a bit better, but still busy.
Thanks, Tisha. Laren, how are you? One of our former fellows, who's a great man, Dr. Tan. It's always good.
Thanks, everybody. Well, Loma Linda is also doing a little bit better. We are still also using non-licensed bed. We're alleviating our sister hospital in Murrieta, just trying to be able to offload their burden there. We are actually consolidating a lot of the other, we say anesthesia, surgical ICU teams. We are moving most of all the COVID patients back to our medical ICU, but we've got close to about 70 that are still within at least Loma Linda Medical Center. So definitely heading in the right direction, but still definitely over capacity.
Yeah, hey, this is Vipul from Fresno. So we unfortunately, Fresno kind of was higher than the state for a lot of most of the past several weeks, as you all know. And we kind of, the winter surge kicked in 29th November or so. And then since then, it has really peaked. It peaked about first week of January for us. So our ICUs, basically, we had 3 teams and we run about 30 patients or so. In the pre-COVID kind of surge, the summer surge peaked at like 50 ICU patients and maybe 200 COVIDs in the hospital. At that time, we had some help. We added a 4th surge team. So for the winter surge, we had planned for that amount of capacity and a little bit more, but little did we know that that was just a dress rehearsal in summer. So this time we peaked at about almost nearly 400 in the hospital, and about close to 100 in the ICU. And we are a small group of faculty, unlike Tisha, like you were saying, you're able to send faculty elsewhere. We have about 12 intensivists in the group, and we're running 7 intensivists in the ICU on a daily basis. So fortunately, we had some help from the other departments, and it has slowed down like it has for everyone. So we're down to about 60 ICU patients right now, and I think maybe about half of them are COVIDs. The recent past week, we have mainly seen non-COVIDs, but they are more sicker, like Davis has seen. The positivity rate in the county was about 27% a few weeks ago. That has dropped to about 11%. So that's obviously a good sign. For some reason, our mortality didn't quite go that bad. Our mortality is about, it's not as good as San Francisco. I think San Francisco's 1 point something. We are, our mortality is closer to 2%, which is not too bad. That's taking the whole positivity as a denominator. So given that we are underserved and a small group, we kind of are hanging in there as of now. So
I think that's the key phrase, hanging in there, which is what most of us are doing. So, and Lori, I just looked up San Francisco is, close enough to have the same epidemiology, far away enough to be different than Sacramento. But yeah, actually our asymptomatic positivity rate, which I was just looking, I hadn't had time being on the ICU, we're at 2.3% with our screening tests, and we're actually at 8.9% with our symptomatic testing. So very similar to San Francisco. So yeah, coming in very close to that. So Denny, I don't know if there's anything else or anyone else wants to give an update. And if not, we can let Drs. Tapson and Morris lead us down anticoagulation, which as these new trials come to the forefront, lots of debate.
I think that's a great thing. I think we'd start and see what Dr. Morris has to tell us.
I like it.
So first of all, thank you very much for inviting me to do this presentation. I'm going to talk with you a little bit about some of the anticoagulation work that's been done recently. And if this kind of gets a little bit too much, just let me know. But I wanted to give everybody a little bit of background information, and I'll have a little bit of time for discussion at the very end. So we're going to talk about anticoagulation now. So, just like everybody else, and this is kind of how everybody looks like they're feeling, is that in March, we thought we were going to just champion through this thing and we're all going to be heroes. And I certainly feel like the marathon runner at the end. I have this talk interspersed with a couple of slides that I just took during the year. This is actually one of those things that you take a quiz and you get out of, and they named it lockdown. And I thought, like, I just can't imagine that they don't regret that name. First thing we're going to talk about is pulmonary embolism itself, because there's an awful lot of talk about COVID and pulmonary embolism. And there were a lot of publications like this where people would go through their CT scans that were performed across these multiple different hospitals and look to see, of the COVID patients, how many CT scans for PE were positive. And people came up with numbers like 22% and 30%, 40%. But what they don't really mention is that there are an awful lot of COVID patients that didn't get CT scans, and they were just looking back on their CT scans. And frankly, if you just look back on your CT scans from the emergency department, sometimes you can have times when they're up to 22% of those being positive. But if you start to separate retrospective reviews of scans from prospective randomized controlled trials, you see a real big difference there. So there's a big controversy about PE really occurs more often during COVID than during similar patients that don't have COVID.
Hey, Tim, can I make one quick comment on that last slide? This is a big. The last slide, the Beigel study, the first ACT study we did, Devereaux, we didn't really collect clot data. So it really wasn't the CRF. So it's really, it could be really misleading just in terms of how you said. I mean, this is a double-blind randomized placebo-controlled trials. You'd think it'd be accurate, but those data really weren't collected carefully. So I think there were a lot more clots in the Beigel study. Just to point that one out, that these studies vary, as you're pointing out, in terms of how they're done and things.
Could be. Would it be fair to say, Vic, that you guys, you didn't collect them, but you certainly kept track of reported adverse events, right? So
Yeah, I can just tell you from our weekly NIH calls, I can just tell you that people, this is I think a big underestimate of what was seen. I don't know what the real number would be though, Tim.
Okay.
Thanks.
Very fair. So if you were to look through the various different reports that have been put out, then you'll see a pattern that's really kind of reminiscent of a reporting bias or publication bias. Is that, you know, no one with a series of 20 patients who didn't see PE is going to submit a paper and say, I didn't see any PE. But if you happen to have had 30 patients and you saw half of them had PE, you're going to write a paper about it. So typically what happens there is that the small number studies always have a big incidence, and when you get to the bigger studies, they get small, you know, the incidence gets smaller and smaller. And that's certainly we saw here. And this is one way of doing it, where you look at the size of the circle has to do with the significance of the study, the power of the study. And you can see as the number of patients get bigger and bigger, the circles get bigger and bigger, but also the incidence of PE comes down both in the wards and in the ICU, and then the studies that looked at both of them. So I don't think, and I could be wrong, but I don't think that the incidence is going to be up in those big giant numbers. So that's kind of where we started with, and saying that, you know, maybe pulmonary embolism that entity doesn't occur, you know, in a crazy numbers with coronavirus. But there is this other entity about microthrombosis, not the big fat clots that you can see by CT scan, but things that you need to look at through the microscope. And this is an illustrative slide that showed, this is a person who had a COVID ARDS, and this is what we're used to seeing, these hyaline membranes, which actually are made out of fibrin, constituents in a blood clot, but you can see they're inside the alveoli, and that results in kind of a typical ARDS picture. But there were lots of reports coming through, and I'm sure that you guys have had the same experience of people that were really sick, but their lungs weren't stiff like ARDS patients are. They had really big compliances. And maybe that some of those people had what I'm showing here. If you look at the arrows there, the alveoli aren't full of fibrin. It's the capillaries that are full of fibrin. That those things, the capillaries seem to be having a thrombosis. It's an endothelial problem. And if you were to look at this is the square on the left, top left there, the A, that's a normal alveolus, a scanning electron micrograph of a normal alveolus. The one right opposite in B, that's a person who died from COVID, and you can see the alveoli are just kind of ratty. You know, the surface of them are just kind of ratty and bumpy and awful looking. And if you look at C there, you can zoom in, you can see that there's little holes and little bumps and everything. And then in D, you can see why. And this is the blow up there is of an endothelial cell, and the virus is actually sitting inside the endothelium. So it infects endothelium and causes clot, which is different than most other things causing ARDS. And I won't bore you with a whole lot of initials, but I can show you here that there's a good theory about how the infection in the endothelium sets off this massive clotting cascade in these microscopic capillaries. So it may be that itself is the thing that is causing the problem, and not the pulmonary embolism that we're used to. So that brings us to a clinical, at least one clinical trial I want to discuss, and this is the one funded by Operation Warp Speed, and this is the Active 4 trial, and this had to do with antithrombotics. So this is a randomized controlled trial that would take inpatients and randomize them either to therapeutic doses of an anticoagulant versus prophylactic doses of an anticoagulant. And the doses themselves were locally determined. It was an open label trial. You randomize into one thing and you just use whatever your hospital uses as therapeutic or prophylactic. The plan was to get 2,000 people in there, and the endpoint was to have days without requirement for organ support. So you get a point for every day that you escape organ support, and if you died, you get a -1. And then there's a lot of different secondary endpoints, and you can see that they were planning on it enrolling for quite some time. And this is actually what I wanted to talk about a little bit, is kind of a unique part about this is that everyone is going through things at the same time. And in a stunning act of cooperation, these 3 different multi-centered trial groups decided they were going to harmonize their trial design so that so they could combine the results, not like in a meta-analysis where there's differences between trials and everything's tough and everything, but these trials are almost identical in their treatment regimens, in their enrollment criteria, and in their outcomes. So it almost, you can combine them sort of as if it was one trial. So these 3 different groups with 3 different funding centers, et cetera, had this extraordinary collaboration. So the numbers can be really legitimately combined. They had they're all the independent platforms. They did have harmonized controls, and they had the same type of endpoint. So it was kind of an interesting idea. So they all decided they were going to do what I described before for the active trial, which is to compare treatment doses of either low molecular weight heparin or unfractionated heparin to a prophylactic dose. And then they were look at people or treat them for 2 weeks or until they were discharged from the hospital, whichever happened first. So the primary outcome, as I said before, that's organ support free days. So it's, healthy days, let's say, or days that you didn't need to have some kind of big organ support. And one thing I wanted to show you here is that organ support was mostly respiratory or vascular hemodynamic support. But there is one thing I just wanted you to keep in mind here is that they called high flow nasal oxygen was also a form of organ support. So you may say, well, that's a kind of a different beast than ECMO or, pressors or something like that, but be that as it may. So the groups furthermore separated people a priori into these subgroups here. They thought there was one would just be ICU patients, critically ill patients, and then another separate group would be people that are in the hospital, not in the ICU. But then they divided those guys into people with high D dimers and low D dimers, and then unknown. So we're going to do separate outcomes for each of these people a priori. And so here's the result that I wanted to talk with you about. Now, this was just put out on January 28th. It was just released by this group. So this is public information, but it's not peer reviewed. It's not. No one's done a peer review of this or anything. They just thought it was important enough that they should kind of share the result. So you can see for the moderate group, the first 3 groups there. The group that had the low D dimer, it looks like there was a superiority to the therapeutic anticoagulation. For both the low D dimer and the high D dimer group, you saw the same number for the missing D dimer, but that wasn't part of their plan. They weren't going to do an interim statistical analysis on that group, but you can see the numbers are pretty identical. Whereas in the severe state, so those are the ICU patients, you actually got the opposite result there. So in the severe state, what they said was futility, which is futility means in a trial that you're unlikely to demonstrate superiority. Statistically, it seems like really improbable that you're going to get to superiority. But frankly, if you look at the numbers, that odds ratio, it looks an awful lot like the treatment group actually did worse, that it was actually a bad thing to do. So we don't, that awaits the final analysis, but they seem like it was just as bad for the severe group as it was good for the non-severe group. And this is a graph to show you that, and let me just take you through that. So this is kind of color coded. So these are all of those states who are going to follow them for 21 days, right? And so since either organ support free days, 21 is, or 22, I guess the best you can do if you left the thing, without any problems there. And the worst is death. If you look down on this, all the red things are things where you got, severely ill, and then the blue ones are where you weren't. So in the first 3 groups, which were the moderate groups, the numbers there, the percentage of people that did not get through the entire thing without requiring support. So you can see in the high D-dimer state, there's a big difference between the anticoagulant, the full dose anticoagulant, which is on the top, and the prophylaxis. I'm sorry, the prophylaxis on the top and the therapeutic on the bottom. So you see that group did worse, and it's pretty much the same for the moderate state. With the low D-dimer. Interesting, the D-dimer level didn't seem to make any difference to this. And then the missing D-dimer looks the same. On the other hand, the severe state is just the opposite. It looks like the people that got therapeutic anticoagulation were the ones that got sicker. And you can see that there's a very, very small amount of people that escaped having any organ support at all. Why? Because that's the ICU group, and that's what they were doing in the ICU, is to get these numbers. So you might say that the last group that maybe there might be some problem with power in the last group. If you got to wear a mask anyways, you might as well do the whole thing. So these are the secondary outcomes now. So these are not the primary outcome, but these are the other things that we think are important. So this is overall mortality, bleeding, and thrombosis in the entire time. So remember, there's follow-up for 21 days, right? And I thought this was significant to show you, because if you look at these numbers, looking up at mortality, the numbers aren't all that different. You know, you go from 5.7 mortality in the therapeutic anticoagulation to 7.7 in the moderate state. That number, you know, I mean, it's 2%, but it's, I don't know if it's statistically significant. It wouldn't surprise me if it wasn't. And it's no fair to do the statistics on this yet, because it's still an interim result. In the severe state, you have this kind of the opposite look. There's a little bit of a trend towards people doing worse with therapeutic anticoagulation than with usual care. But again, you know, not a good idea to do statistics on this stuff yet. As far as major bleeding, it's exactly what you'd expect. There's a little bit more major bleeding in the when you get therapeutic anticoagulation. That's in both groups. And then for the thrombotic events, the moderate state, thing to zoom in on there is that although you had a little bit more thrombosis in the usual care, that's not surprising. They got lower doses of anticoagulation. It wasn't really, that's, you know, the absolute value wasn't that much bigger. They got 1% more thrombosis with the therapeutic anticoagulation, or fewer thrombosis with the therapeutic than the prophylactic one. In the severe state, and we're going to come back to this in a second, they actually had a fairly big effect of getting a lot of anticoagulants. So the usual care people got about maybe a 12% incidence of thrombosis of some type, and you can see there that's DVTs and PEs and MIs and strokes and everything. So this wasn't like massive PE, this was everything. But that happened about 12% of the time, which is what we see in the ICU, and it's not surprising that it was less, but it actually really did cut it down to just about in half. Other COVID, I don't know if you guys remember this, but the engineer who wanted to run his train into the Mercy here actually just didn't do his physics homework, because that's about as far as he got there, if you remember that. So now if I took a couple of those slides and put them together now, so this is the outcome trial stuff on the left. This was the primary outcome. And then we talk about the thrombotic events on the right, which is really where we all started with this. Let's see if these guys were all dying from PE. Let me gray out the severe ones there, then show you that the bad outcomes happened in the prophylactic group, to a much larger extent than in the other group. But look over to the right about the thrombotic events. The thrombotic events only happened, you know, maybe 1% more times. So it would be very hard to explain why these people, you know, that went on ventilators, et cetera, if they had a 1% absolute increase in all thrombosis. That includes DVT and PE and all that stuff, you know. On the other hand, in the severe state, those are the guys that you actually prevented the thrombosis, the large vessel thrombosis with the high dose anticoagulation. But those are the guys that had the bad outcomes. So I think that all putting this all together, it suggests that it's not those large vessel thromboses. So that's not the issue. The issue is that we may have found a way to prevent people from getting the small vessel, angiopathies, et cetera. So yeah, this happened. This was San Diego, actually. I love the fact that this guy showed, I think this guy went to the wrong parade. I'm convinced he put that dinosaur outfit on and he just got lost. He thought he was going someplace else. So anyway, So maybe COVID is a lie, but just in case, we should talk about at least what the group, the NIH group, suggested, which was they are saying in a moderate state, you probably should put people on therapeutic dose anticoagulation. And they said you get a low amount of bleeding and it has a good, trends towards morbidity and mortality. Whereas in the severe state, it says that therapeutic heparin does not improve organ support free days, but I would say that those numbers look like they actually made it a little bit worse to me. There was some increase in bleeding and, mortality. So one other item that they mentioned was this trial is still ongoing, and as people go from moderate to severe, when the trial was ongoing, they went from moderate to severe. So they went into the ICU. What should you do? And they were how the trial went, anyways. It was even though we had already found out that it was not a good idea for ICU patients, if people went from moderate to severe, they continued on the anticoagulation. So this is not clinical advice. This is just to say in the trial, if a person went from a ward patient to an ICU, if they had already started the anticoagulation, they continued it. So you decide yourself. So as far as discussion points, this is a picture from Santacom, which one of these days I have to go to. But between now and when these results come out and we can really tease out the effect, et cetera, there's a possibility that full dose anticoagulation will help stable people from developing these microthrombi or something. But if you're in the ICU, that's probably not the thing that's going to happen, or maybe it already happened, and now you're in the ICU and you got other things to do to help besides anticoagulation. But I do think that it's important to think that these results should not be mistaken for the thought that these are pulmonary embolism that are coming up, and we need to do something. We need to do more scans than we normally do, or treat these people as if they all have PEs, because it doesn't look like that's the issue. So I'll stop with a thank you to everybody that's been standing there on the front line. This is my favorite memory, or one of mine, is when all the cops and the firemen, et cetera, came outside and applauded all those folks who were stuck inside. So let me stop there, and I'm going to turn it over to my co-presenter, Vic, to tell you the real story. So what do you think of all this, Vic?
Yeah, I've got about 117 slides, Tim, so I'm gonna have to go through them pretty quickly. I'm glad you did a nice job, Tim. I didn't make up slides. So boy, I'll tell you, great data presentation. I think the multi-platform trial concept is awesome. I mean, there were some little differences between ATTACK and Active 4A and Remap Cap, but not much. I mean, I think the way they put this together was pretty impressive. I still don't know for sure what to do. I think, and I'd love to hear what everyone else has to say. We'll have some great Q&A. I think the comments I guess I would make right now is that in inpatients, I still think appropriate dose prophylaxis makes sense for most of our mild COVIDs, if you will. We've argued a lot about intermediate dose prophylaxis and full dose anticoagulation. When New York was on fire early in the pandemic, and many of our colleagues back there said this COVID thing, we're seeing more PEs than we've ever seen before. It's unbelievable how many we're seeing. And we didn't see that many. We enrolled 40, 50 patients in each of the NIH COVID trials. And so I felt like we were pretty busy with COVID, and we weren't seeing that many pulmonary embolism cases. So I was kind of wondering what the scoop was. But I will tell you now, after the surge, after the holidays, our normal PE response team, 1 to 3 PE consults per day, has increased some, and now is about 1 to 2 COVID PE patients per day. It's hard to know how many that is. The ED, we get called a lot for the pulmonary embolism cases. I've noticed this week, it seems to be less. It seems distinctively less to me. George talked about our stats, and our numbers seem to have leveled off. A few weeks ago, 2 or 3 weeks ago, I was just aghast at how many pulmonary embolism cases we were seeing with PE. We have a study we're doing right now. We're looking at, as you know, Tim, tenecteplase in acute PE in the setting of COVID. And so we're getting maybe more calls than we would otherwise, I don't know. But just seeing a lot of pulmonary embolism cases. So whether that is truly the inflammatory state of COVID, whether it's reduced mobility from quarantine, I don't know what it is, but I still think we're seeing a lot of pulmonary cases with COVID. And the one point I'll make real quickly, and again, I hope we can maybe just open it up to everyone pretty soon, and that would be, what do we do at post-discharge prophylaxis? You know, George and I have talked about this a lot. Our committees have talked about it for a pretty long. I think based on the fact that COVID is an infectious disease, if you believe the Magellan data, you know, we did that Magellan study, and then the subsequent study where we excluded high-risk bleed patients, and the data looked pretty darn good. And of course, one of the inclusion criteria in Magellan for post-discharge prophylaxis, and you guys know the Magellan trial, we randomized patients to Xarelto in the hospital for prophylaxis at 10 milligrams once a day for the subsequent 30 days or so after discharge, versus just the typical no prophylaxis after discharge. And so we saw benefit from Xarelto, and it was quite safe at 10 milligrams. We didn't see a lot of major bleeds. We didn't see a lot of major bleeds in Einstein Choice on 10 milligrams. When we treated patients, when we dropped the dose of Xarelto to 10 milligrams after 6 months, we saw a clear benefit in about 0.3 to 0.4% major bleeds. So anyway, what my diatribe is kind of getting to is that, you know, at first I wasn't so sure. I believe the Magellan results, and you could just lump everybody with COVID into Magellan if you want to. I think what we've done at Cedars is we've individualized patients, which I think you always have to do. You just have to look at the patient. You can't say we're doing this to everybody. At least that's the way I felt about this. But more recently, I've almost felt like we should, just based on the numbers. We've had, you know, 2 or 3 in the past 10 days. Patients come back, discharged with COVID 3 weeks ago, came back with big pulmonary embolism or DVT. So I'm kind of a believer now that risk benefit for post-discharge prophylaxis for 30 days makes sense, whether you go by the Magellan data and say it's an infectious disease, or say COVID is prothrombotic and this is a problem. So that's kind of my thoughts about it. I think we have a very low threshold, even though early studies aren't really showing much in terms of VTE. I just don't know if those studies were done right. We're looking at the right patients, and I do think we're seeing it. So I'm really eager to see the final results of the prophylaxis studies, and so we really do know for sure what to do instead of just guessing. But having said those things, again, thanks, Tim. That was a great presentation. Maybe we could should we open it up, Tim, for comments, or what do you think?
Yeah, so I'm going to read a couple of comments off because some of them are similar. So there are 2 comments from 2 wonderful centers, actually, both of which said they talked a lot about the bleeding they were seeing. And I think I would echo that we have seen an awful lot of bleeding when we've exceeded the prophylaxis recommendations in critically ill patients. You know, and interestingly enough, we all did this because, as you said, both in Europe and in New York and in Boston, people were pulling the trigger and saying, we're seeing a PE, everybody's dying of PE here. We got to, you know, keep that from happening. And we did the same thing, I have to admit. We said, well, okay, well, that's what you're seeing. And we went on this high dose anticoagulation stuff, and we started seeing some really bad outcomes from bleeding. So I think that in the ICU anyways, I think that we should treat these ICU patients like we treat every other ICU patient, and not exceed, you know, recommendations regarding prophylaxis, or else we're going to run some risks of bleeding. So would you agree, maybe Vic and anybody else on the line, is there anybody who thinks that with the ICU that we, you know, really ought to be pushing the anticoagulation a little bit more?
I think you're right, Tim. I'll just make my one comment. And I think, to me, discharge prophylaxis, I'm kind of a strong believer we should be having a low threshold to do that, individualize patients and send them home on tenorivaroxaban based on Magellan or COVID, wherever you want. But get the data. We need to get these data so we really do know what to do. But I think you're right with the ICUs, Tim. I really worry if we do that indiscriminately. I think you're right about these data. They're interesting. They need to be peer reviewed and published. We need to look at them carefully. But you're right. We didn't see a huge difference in these outcomes. So it'll be interesting to see what the statistics really show. I would be really concerned about bleeding if we up the dose to therapeutic in everyone.
What about I'm actually very interested in you know, you guys have seen now what we see and we know, you know, and so you've seen the data in the non-ICU patients, and granted that's not usually our cup of tea, is to go out and see a ton of the non-ICU COVID patients, but they come to us when they get sick enough, right? So I think that people are going to, if we're not taking care of them personally, we're certainly the ones that our hospitalists are asking us advice for. I know I'm going to be getting these questions all the time, you know, as people start reading the newspaper about, you know, God, anticoagulation keeps people from dying and everything. And I'm personally, I'm not as enthusiastic about jumping on that bandwagon right now, because as I was shown before, part of that outcome could have been people getting nasal high flow oxygen. And I'm just not sure that I could say that I've done somebody a favor by giving them full dose heparin to keep them off of oxygen for a few days. And I just don't know. When the publication comes out and it's, you know, things are teased out a little bit more, I think I'd be able to say. But what do you guys think?
You know, we talked about it at Davis, and we talked about this data rounds today a little bit. And, you know, I would agree with you. You know, obviously we want to see the data. You know, the different subsets under severe were not necessarily one of the primary endpoints, but I'd like to see how that teases out. But, you know, it gave us pause. You know, we were much more indiscriminately anticoagulating. We ran higher anti-10A levels, you know, especially for our patients who were just profoundly hypoxemic, where we were proning them. They were not candidates for ECMO. We were struggling. We thought, okay, let's push up their anti-10A. Maybe that's going to help. I think that's really put pause on some of the things we otherwise would have done, because really do no harm is our first step. And if that's going to cause harm and not give us benefit, you know, we have a little pause with it. But of course, I'd like to see the data. We feel much the same way.
And maybe we could ask, so I think we're all going to be probably cautious, especially based on the severely ill patients. We definitely don't want to do harm in anticoagulation those folks, and the moderately ill patients, those that aren't in the ICU yet. You know, what do we do there? Some people are still doing intermediate dose prophylaxis. We're still sticking right now with 40 milligrams of enoxaparin for most of our COVID prophylaxis. I just don't know if there is a group that might benefit from intermediate dose, and I can't wait to see the rest of these data. What are people doing at discharge? Is anybody doing a post-discharge prophylaxis now with COVID, or?
We don't do it routinely, and that's certainly part of the Active 4 trial has an arm for that sort of thing, and I think we're just kind of waiting to see what happens. But I don't think that I think you may raise a very good point that if you extrapolate the results from non-COVID trials like the Magellan, it seems to make sense, but we have not adopted that yet. By the way, I'm also reading the chat box here, and I see my good friend Elon Hecker, they just weighed in and said that it's really important that we don't lose track of the lessons that we learned over the decades about ARDS, because in many, many ways, this is a viral pneumonia that causes ARDS. And I know that there are some differences, and we highlighted some of them tonight, but 90% of this is probably stuff that we've learned the hard way, and we need not relearn it the hard way again.
Yeah, in response to what Vic was saying about anticoagulation, it's at least in my side at Scripps in San Diego, we've not been routinely sending people home with prophylaxis. We have seen some people come back with PEs, but not a lot. I mean, it's been a relatively small number. But more importantly, we've spent an hour on this talk, and only just now have I noticed your tie, Tim. That's fantastic sparkles that you have.
I like yours too.
Yeah, thanks.
Yeah, I don't know the answer to the outpatient prophylaxis, except I always go back to Einstein choice. That was a therapeutic trial, of course, and that was in patients that were 6 months out from their acute event. But the dose of rivaroxaban in that study, the 10 milligram dose turned out to be as safe as aspirin. The major bleed rate was the same, almost the same as for aspirin, 0.3, 0.4%. So when I think about that, I think of risk benefit, and to me, again, I still don't think we should indiscriminately do it. I still think you have to look at the patient, and maybe, but once I do that, I think I have a much lower threshold. But you're right, we'll wait for Active 4, some of these data, and see what we see, and then we'll know for sure what to do. But I think prolonged ICU patients have reduced mobility when they go home. Patients going home still on oxygen, which is happening, aren't getting around very well. I think a very low threshold does make sense to me. I mean, we've had to wing it in a lot of areas in medicine. Remember, we first started doing lung transplants. Remember how we winged it? We didn't know what we were doing in terms of rejection, infection, and when to do bronchoscopies and what the biopsies meant. And I think in some ways, it's kind of like the Wild West again, a little bit, but looking forward to more data.
So there's another question from another good friend, Ben Ashlock, who's making a comment about D-dimers and whether that should drive a decision about what type of anticoagulation you should use. So what are your guys' opinions about that? Should we pay more attention or less attention to D-dimer levels?
It's a tough one, Tim. You know, I guess one thing I would say is I remember seeing a patient in the ED about a month ago, 30-year-old woman with breast cancer came in just very sick, hypotensive, very, very hypoxemic. X-ray was pretty unimpressive. We were talking about giving her TPA there in the ED. We didn't have a scan yet, and her D-dimer was greater than 20. It was markedly elevated, and it was very tempting. We couldn't get good windows on her echo, and we said, well, she got a little more stabilized. We had her on pressors, but not wide open pressors. We got her to the CT scanner. She had no PE. And I would have bet she had a PE. And she turned out to be very septic. And sometimes really early in the game, it's hard to tell. You'd think that'd be a slam dunk to be able to tell the difference, but really early, sometimes it's hard. So I think I'd be cautious with D-dimer. I think it's one point. We've seen data suggesting that the height of the D-dimer in acute PE patients, not in COVID patients, the height of the D-dimer is associated with mortality. The higher D-dimer, more likely to die from PE, which maybe makes some logical sense, but I still don't know. I'd love to hear what others think about that. I'm not sure. I just feel like I've been burned a few times thinking someone has a PE and then they don't have one.
Yeah, you know, it's funny, our residents, this came up today, they presented a patient with E. coli bacteremia that was on 2 pressors, and they started reading me the D-dimer trends from the night before. And then I was like, did I miss it? Do they have COVID? And they said, no, we're telling you about their D-dimer trends. And I'm like, oh my God, you guys haven't, you know, this pandemic has ruined your understanding of medicine. This is terrible. So it's just fun to watch. I mean, I think here we've had this issue where, you know, hey, your D-dimer is 3,500 or it's 10,000 and the anticoagulation has to be this. But I think teaching people to put that in context. I mean, if your D-dimer is 3,500, you're on the floor and on 4 liters nasal cannula for 600 and, you know, you're intubated and being proned. I don't know what to do with that. You know, that's just not going to change anything. So I don't think it drives a lot of what we do, although as an institution, it is driving a lot of what we do.
Yeah, I think, you know, the thing about the D-dimer level is, you know, there are 2 things to keep in mind about it. Number one is that a lot of the work, most of the work was done in people that didn't have any other diseases. So they're trying to differentiate healthy, worried people from people that have DVTs, but no one ever tried to tell the difference between appendicitis and PE that way. So those numbers have never been worked out. And number one, and number two, the D-dimer level is probably more useful if it's extremely low and it makes you feel a little bit better about not going, you know, taking the next step, than if it's high. And there really isn't a lot of data to suggest, you know, if it's really high, then you know, you're more likely to have a PE than another thrombotic disease. There is data to suggest if it's really high, or like to have a PE than nothing, you know, than a pulled muscle or a, you know, worried, you know, whatever. But I think, you know, somebody's already got COVID or you know, sepsis for that matter. I'm just not sure what that really does for you.
And along those lines, Tim, I kind of wonder, it is hard to decide who to look for PE in when someone with COVID tips. I think when they tip over and you see the x-rays much worse, we're usually pretty comfortable. That's what's going on. You know, we're actually fortunate. We do portable perfusion scans at Cedars, and we do portable VQs now in COVID, really portable perfusion scans. And we found them several times. We're doing one right now. We're waiting for a result right now in someone that probably doesn't have a PE, but it's been very helpful because even though these portable scans are often non-diagnostic, especially with COVID infiltrates, usually you can tell. I mean, if you get enough perfusion, you can say to yourself, well, PE is certainly not why this person's on 3 pressors. I'm not going to give TPA. There's a lot of perfusion here. There's some defects that maybe are matched, maybe a few little mismatches, and they could have PE, but I don't think PE is killing them right now. The portable scans really, I think, been useful for us in some situations. But I guess one of my issues that comes up a lot is just who do you look for PE? And it just seems like it's so easy to say, in so many patients, we really ought to make sure this person doesn't have a PE. Has anyone come up with some ways of I mean, screening echo, scan the legs, any systematic way of sort of deciding who to look for PE in when they're sick COVIDs?
Well, you mentioned, Vic, sometimes the correlation or lack thereof with the chest X-ray, and that's something that I will tend to think about more. You know, if they're getting much more hypoxemic, but the X-ray looks the same, you know, then we might trigger with an echo and a Doppler. If those are negative, maybe go to a CT scan if we're still suspicious.
Sure. I think it's a great point, Kevin. That's probably maybe the best differentiator, the most useful one.
Vipul in Fresno says they're trying to proactively look. Vipul, do you want to share?
Yeah, I mean, you know, we've been trying to look proactively when we can. If the D-dimer's been especially more than 5,000. So as an institution, we kind of have been using high intensity prophylaxis as a dosing of 40 BID of Lovenox with that higher D-dimer, but then at least we scan Doppler the legs, and if they're not too hypoxemic and able to make a trip to the scanner, we look for PEs. But I've been very surprised with having the same D-dimer level, and one shows up sprinkled with clots, and the other one is negative, like the case was mentioned. So it doesn't seem to be very helpful. I know other centers at the East Coast that use a cutoff of more than 10,000 and just initiate therapeutic anticoagulation, but we haven't done that. But we do use it if it's upwards of few thousand. We do try to actively look for clots and have not found a correlation. Just by what I can tell, we haven't systematically looked at that.
You know, I think that's a mistake, and not what you're doing, but I think that's a mistake to base anticoagulation on a really high D-dimer level. I mean, you saw those histology slides of both ARDS and the angiopathy, and I just don't. I mean, and I think the data that we just reviewed kind of backs that up. That a knee-jerk response to a high D-dimer level is probably not a very good idea.
It would be interesting to know, Tim, if a high D-dimer level did correlate with, in those folks we don't see PE, do they have microthrombosis? Is there widespread microthrombosis causing elevated D-dimer? We do the scan, it's negative. We say, well, there's no PE, so D-dimer doesn't correlate, and maybe that's true. It would be great if somehow we could get more data. We don't have a microthrombosis scan right now, but we'll have to figure that out.
Yeah, the dosing of kind of high intensity prophylaxis, I don't know what good it is, Tim, like you said, but we don't therapeutically anticoagulate them. But yeah, for whatever it's worth, we've been using that protocol of instead of 40 daily prophylaxis, it's BID.
Yeah, Shazia, I think you had a comment or a question.
Yeah, hi, Vic and Tim. So wonderful to see you again at CTS. We talk a lot about RV strain, but my issue is working in the ICU, unless until we have a baseline echo or something, and now the patient is worsening, how would we know that this RV strain is secondary to PE versus due to very severe ARDS and severe hypoxemia and pulmonary hypertension? So that is something that I struggle with.
That's a great point. And I think I wouldn't classify it the same as the D-dimer, but I tell you, we have been burned before. With a patient we're waiting for right now is a bad looking RV. I think they're probably septic. We're waiting for the perfusion scan. But I think looking at the RV can certainly be helpful. You see a McConnell sign, you see a big bad looking RV, it certainly suggests PE. And we've certainly treated certain patients like that empirically when we couldn't get any more data. But I can absolutely say that we've been burned more than once, assuming someone had PE, and the RV just looked like they should have it, and they don't. So those are among the tougher decisions. I'm really sick, especially when someone you can't move, you don't have a portable perfusion scan. They're tough decisions, and we pulled the trigger a few times, but I would just advise caution there. I just think when everything points toward PE, you got to make a decision, but I just say it's not perfect. It's not perfect. It's pretty good, but we see these comorbid patients come in that have sleep apnea, they're obese, they have other problems. They have ARDS, they may have COPD. But even when they don't, I think sometimes you just got to be careful. It's not the RV view is not a diagnosis of PE.
So that's actually been looked at in other settings in people that have respiratory failure. And so that's different to say if, somebody's in the emergency department and they're worried and that's right. But if they're in respiratory failure, the echocardiogram showing RV strain had like zero discriminatory value between people that were in ARDS and people that had big PEs. So, I mean, it certainly would be a reason if you see it to say, well, I'm going to take the next step. And especially if you had your clinical sense was that there's a PE is possible, but seeing it and you're just seeing the RV being big, even acutely big, which is what that McConnell sign is that, just like the RV hasn't really adapted to that high pressure. I would say would be cautious about using that as a hard diagnostic criteria to say you need to give anticoagulant. The one exception, as far as I know, and as far with the echo, is that sometimes you can see a clot. Actually, you can see it in the pulmonary artery. If you do like a TEE, you can see it there. But I hardly ever see those things on.
I would just add, Tim, that you're right. I agree that you got to be really careful in the really sick patients. In the patients that aren't so sick, again, it's kind of like the X-ray analogy. If someone's got a bad looking RV, you can't easily explain it by their lung disease or respiratory failure. Certainly then I would have a lower threshold to empirically treat if I had to. But then again, if someone's not that sick, usually you've got a little time and you don't have to empirically treat with at least thrombolytics or something.
I agree. One thing that I think that we've learned, and this is along the lines of Elon Hecker's comment from earlier, is that I think we've learned that doing CT scans on these people is probably a pretty good idea if you can do it. And I think we were all very, very worried about putting a COVID patient in the hallway of the hospital and taking them down the CT scanner. But I think that we've learned how to do that well. And, we do that, routinely. If we don't, keep people from diagnostic tests if they have COVID, even if they have to leave the room for it. And our COVID transmission to our healthcare personnel and to other patients is zero. We've done fine there. So I think that's a lesson that we can relearn is like, just, do the scan, do the right thing, figure it out. And don't be too worried about, having a person leave the room to get the right thing done.
Well, thank you both for this amazing discussion. I think we have just one more comment or two. One, what the echo showing thrombus in the ventricles. So thank you. The echo was useful. But Uma, do you want to say something about you're consistent with what they're saying as well?
Yes, hi, this is Uma. I work in Kaiser and Santa Clara here in the Bay Area. It's been the same experience with us too. I mean, I don't think initially we were really relying on D-dimer to see whether we should scan these patients. We were worried about, sending them for CT scan. But as we've started taking care of these patients more and more, the D-dimer level could be elevated consistently. And, we've scanned them and no PE. And I think, the recent data totally makes sense. It's not just looking for PE, the level of microthrombi, which you're not going to catch in a CT angio. So D-dimer could be elevated. So I think, I've just stopped following D-dimer. It doesn't make sense to me anymore. And definitely if there is any worsening, if there is no change in chest x-ray, but worsening hypoxia, definitely we've been doing bedside ultrasounds and echo if I can't scan the patient. So yeah.
That's a great point, Uma. I completely agree. What do folks think about it? Have you folks seen heparin resistance? We've seen some heparin resistance. I think at least patients who aren't getting where we want. And my thoughts, I always have advocated trying to use low molecular heparin even more than we should use it, I think, when we can anyway, just because of bioavailability and not monitoring. But I always think of the analogy when you think of heparin going and binding to antithrombin, heparin, we call heparin a promiscuous molecule. And it binds to a lot of different proteins it sees in the bloodstream, not just heparin. So we weight base it, we do the best we can. And we're seeing, of course, tons of inflammatory proteins in COVID. And maybe it makes even more sense than usual to try to use low molecular heparin when you can. Obviously, if there's a high bleed risk, you're watching someone closely, we keep monofractured heparin so we can stop it quickly. But I wondered if, and for example, argatroban, it seems to be even lower risk for problems based on the fact that you don't see resistance. So it's been reported. We seem to have seen it. Maybe it's not as big. I saw Tim kind of shaking and said, no, maybe it's not as big a problem or as widespread as some people might think.
Yeah, I don't know. I mean, I didn't mean to non-verbally diss you there. I just haven't seen it. Not to say it doesn't happen. And I wonder, by resistance, do you mean that you're having to use this higher amounts to get an APTT, or that they're actually the anti-10A levels are not what you expect them to be? Because if it was anti-10A level, it had nothing to do with your own antithrombin, because that's from the lab, right?
Yeah, I agree. And what we haven't seen, I'm not sure what others, we haven't really seen anticoagulation failures. We haven't seen people go home on anticoagulation with PE and COVID, or having DVT or P and recurring on therapeutic anticoagulation. So from that point of view, I feel like we're okay. We've seen tons of PEs. We'll see 600 or 700 of our PE response team this year, and I don't recall cases of COVID PE that have recurred on anticoagulation. So that's coming.
So I have a question just to bring us back to the newspaper stories. I would love to hear from people, especially people who haven't spoken yet. Maybe just so that you can testify in my malpractice trial about whether you would take people who are currently on the wards who have COVID, who don't look too sick, and would you jack them up to full dose anticoagulation now based on the evidence that you saw already? Or would you say, interesting, good reason to keep our eye on the literature, and let's wait till the full edition comes out and the ink is dry? So would anybody, as of tonight, change all of their hospitalized COVID patients to full dose anticoagulation?
I think in the absence of a large vessel clot, and we're just thinking microthrombi, no.
I don't know. I'm on the fence about it. I'm bothered by, the data didn't flow exactly to me, but it's hard to ignore it too. So I don't think anybody be wrong to do it, but I'm not sure I would say that you're absolutely doing the wrong thing if you don't do it tonight.
I would still say we're probably back to individualizing patients again. I wouldn't do that without individualizing. If I saw someone that had many things, multiple risk factors in addition, maybe I would let a very high D dimer enter the equation. I would be cautious not to use that entirely. What about others? What do you guys think?
Angela just said Ayana might be on the line and have an opinion. I don't know if she's still on.
Tim, it's Elon. I 100% agree with you that, we've looked at this before in sepsis and in so many other things. We've looked at anticoagulation and it hasn't been borne out. So I wouldn't fault someone if they wanted to go ahead based on this early data. But I have to admit, I've been very, very nervous when we start using things based on the interim analysis of a phase 2 study, or the interim analysis, or based on something you read on CNN and it hasn't been published in a peer-reviewed journal. We have all these questions: were the patients who benefited really the ones who were just put on high flow? We have so many questions that, sometimes I think it's best, even though we're all critical care doctors and we want to jump on board with ivermectin and vitamin C and all sorts of things. I think sometimes, our colleague from UC Davis said the same thing, that you just kind of have to be patient, kind of sit and wait. And there's a process. The scientific process is something that we believe in. And if we throw it out the window because we're in this panic of COVID, then I think we're no better than the press. So I think we're asking all the right questions. And like I said, I wouldn't fault someone based on the evidence that we have. This one makes a little bit more sense than some of the other things. But I hope that you'll defend me when I stand, in court, because, I'm not too excited about personally being the one to full dose anticoagulate. As far as post-discharge, I think, as Victor Tapson mentioned, we've got really good data even before COVID to suggest that in the right patient, sending them home for a short term on low dose anticoagulation is safe and effective. So, that data has already been published and relatively substantiated. So that seems a little bit more reasonable. We're doing that in a very select number of cases. We're not doing widespread, but in patients that we think that are in the highest risk quartile, sending them home on 10 milligrams seems very reasonable.
Well, we definitely have to read the studies carefully. I'm still not, I don't know how you feel about this, Christian. I'm still not comfortable with the recovery trial, honestly. I think the recovery trial was not, we're using dexamethasone as standard of care, and I do frankly believe in that. I love steroids. I mean, those kind of steroids for sick people.
I knew it. I knew it.
But I got to tell you, you look at how the recovery study was designed. It's not a perfect double-blind randomized controlled design, and we're going by that. That's why we have the baricitinib dex study right now. I think. But in any case, I think your point, Tim, is well taken. Elon's as well. We got to read these studies really carefully and read the data and make sure they're at least finalized before we jump on the bandwagon too much.
Yeah, I know. Along those lines, we had a response here at UCSD that I'm not sure that I would do again, but we decided that we were going to do like top-down management. So we would cede some big decisions to the people that were in charge, and they would say, this is how we're going to treat everybody. And we did that with oxygen and with contagion prevention and antivirals and anti-inflammatory, et cetera. And so we'd all get together and make one decision, and then everybody had to follow it. Over this thing, I don't think the data are there strongly enough to support a top-down decision either way. Like I think it would be wrong for a center to say, don't do this. And I think it would be wrong for a center to say, everybody has to do this. And I think we're still at a point where, there's enough uncertainty that I think we can all use our, our degrees and in our clinical judgment.
Thank you, Dr. Morris and Dr. Tapson, for this excellent conversation. I think you've held everybody just spellbound on this topic. And we really appreciate your time and sharing this knowledge, because it is reassuring to all of us, because the way it was announced and it's in the media and in all our news feeds, seems like we better be jumping on fast. So thank you very, very much for tempering this and for everybody on the call. And then Christian had some questions, maybe, I don't know, for the last 5 minutes. Christian, did you want to throw these out there?
I don't know, there's a bunch, and I'm just curious, these are coming up, and I draw these partly from our rounds, but partly from, what we hear from transfer centers, prior calls here, and it seems like my ARDSnet has an extra D in there. The only one I'm curious are probably the last two. I get a number of odd calls about the use of tenecteplase, half dose, in patients who are just sort of profoundly hypoxemic and refractory. And, it's funny, people ask me what I think of it. And I'm like, I don't have the data. I don't feel comfortable. I'm just treating them as ARDS like I always have. And then usually most of the people calling for transfer will say, well, I use it and it's wonderful and it's great. So I'm just curious, because this sort of surprised a number of us. Are any of you using that? And this is obviously in the absence of known clot. This is all for microvascular disease that's predominantly thrombin driven, as we talked about tonight. But I just was wondering if anyone's used that, whether it's been with RV failure without a PE, or whether it's just been refractory salvage therapy.
Well, the Mount Sinai study is ongoing right now, looking at that with tenecteplase. Our study is for macroscopic PE, and I'll just tell you, our study is proven PE. I'll just mention, I had trouble with it because it's a randomized, double-blind, placebo-controlled trial, and I often don't have equipoise. There's times I really don't want to give it, and there's times when I really do. So it makes it tough. But I don't know. I think that's in one area we really need the data. As you well know, thrombolytics are really dangerous, so I think it may depend on how sick the patient is and whether you're ready to just say, I got to do this. But to do anything routinely, I think it'd be tough. What about others? Other thoughts?
For my 2 cents, I wouldn't use it for the microvascular disease. I just think it's a different thing, and it maybe I'm actually kind of a skeptic about thrombolytics, anyways, and maybe I'm like the last remaining skeptic about it. But I think that the action that thrombolytics have is not to eliminate all clots in the body, which I think is kind of the name itself as a misnomer. But what it does, I think, is it shaves the side of the clot down a little bit just to get some blood flow so that you can restore the right ventricle and get it, you know, away from being infarcted, et cetera. And so I certainly do use it in cases where somebody is hemodynamically in trouble from a PE, but I have no illusion that after it's done, the PEs are gone. And I just don't have the same model in my mind behind those capillaries, that these little strings of fibrin in there, that if I can just shave down half of the fibrin diameter, that somehow the person will do better. So I'd be really cautious about using fibrinolytics for that indication.
But remember, Tim, and I won't say you're wrong. I'll say if you could shave down half the fibrin in a capillary, remember Poiseuille's law. Flow is proportional to the radius of the vessel, the fourth power. You improve that radius by a little bit, you get much better flow. So you may well be right, Tim. I'm not saying I'm right. I'm just saying if we did know it did that in widespread microvascular thrombosis, I think it'd be pretty neat to look at. And we'll see what Mount Sinai study shows. But again, you're right. We don't have the data.
Yeah, but I just didn't pull up Poiseuille's law out of my back pocket just now to.
Poiseuille.
I thought it was Poiseuille. No,
I mean, maybe it is. I don't know. I'm not French.
I'm gonna ask him. He's sitting right here. I'm going to ask him later.
Okay. Yeah, perfect. This is good. I know we have a few minutes left. I mean, you know, the only other thing that's come up, I don't suspect any of you guys have started using baricitinib regularly. We have not. That hasn't made its way for a number of different reasons to us. I'd love to hear if someone's using that. And I did see your message, Tim, in the chat about using remdesivir even on severe patients. We have not gone down that avenue. Really, actually, dexamethasone is all we're regularly using on our critically ill. So, but I'm curious if, you know, we obviously are always looking for the optimal driving pressure, particularly keeping it below 15. Most of us in the faculty will, you know, calculate a stress index to help find the optimal PEEP, but it's sort of fallen in a window where we're actually, a majority of our patients, particularly early in the disease, when their compliance is good, they're profoundly hypoxemic, and we think there's a lot of vascular disease, we're sort of mirroring the lower ARDSNet PEEP FiO2 ratio tables. And I'm just curious, I assume you guys are all seeing that, and if you've sort of made a shift in that direction, because that's something we've noticed, which I think our PEEPs have been significantly less than what we're used to for any traditional form of ARDS in general.
You know, so we use the ARDSNet PEEP FiO2 ladder regularly enough that it's now a respiratory care protocol. You can order ARDSNet low PEEP or ARDSNet high PEEP and let the respiratory therapist come in and adjust both things up and down, which is nice because, you know, you always, you know, people forget, you know, when you're trying to do, you know, you get up on this, you forget to do that or something like that. So we've written it that way. I do agree that there are people who, and I think it's because they have a capillary problem, that don't fall into the ARDSNet a model. For what it's worth, when you chop up the high PEEP versus low PEEP ARDSNet trial, it looks like people who are the sicker ones were the ones that benefited from the high PEEP arm. You know, if you divided them up to the sicker half and the non-sicker half. So I think if somebody's very sick and they look like they're very, very non-compliant, I think it's an okay thing to do to go into that high ARDSNet ladder. But I think it's really useful. You know, it's funny that we still don't know how. We were talking about lessons we've learned. There's you know, half dozen different ways to adjust PEEP, and I don't think anybody can say that one is better than another as long as you have a plan, you know.
I just say, as far as baricitinib is concerned, we're doing the baricitinib dexamethasone trial right now. It's about maybe almost half enrolled, about 400 and some patients enrolled. I'm not sure what the goal will be. It'll enroll somewhere around 1,000 patients, I think. You know, I don't know. I like dexamethasone. I don't think we get into big trouble in most patients using it. Baricitinib is a JAK inhibitor. It may have less side effects, less blood sugar problems. I don't know about less infections. It's an oral drug. And you know, one of the issues with it is when someone can't take oral, you know, you miss the drug, or you know, if the lymphocyte count drops too low, drops below 200 absolute, you can't give it. Renal function gets too low, you can't give it. You have to cut the dose in half from 4 to 2. So we're not using it routinely yet. I really hope we get something useful out of this study. So I hope in the next couple of months we'll have something there from that study.
Yeah, agreed. Okay.
You'd also mentioned or asked about inhaled nitric oxide, and frankly, I don't jump on a lot of bandwagons, but I think that inhaled nitric oxide got a real bad rap when it first came out, and everybody remembers about inhaled nitric oxide that, you know, it improves oxygenation but doesn't improve mortality. But that's an awfully high bar, especially for the trial that was done to say that that's a fact about INO. And I can personally say there are plenty of people that we use inhaled nitric oxide on. It's helped their oxygenation great, and they've gotten off the ventilator eventually because it got them over a tough time. So we use it all the time, and I think it's a good idea for these guys.
Yeah. No, I last week I walked by. This was one of our gentlemen who's you know, in his 30s, pretty sick, and just like all of you, you know, just profoundly goes through periods where his pressure drops, and you put an echo probe on, and his RV is, you know, just amazingly dysfunctional. And I walk by and I'm like, what are the fellows doing? And I go and there's 3 fellows in the room. They got a probe on this guy's chest, and they're playing with inhaled NO levels, and, you know, bouncing around between 15 and 40 parts per million. And they're like, hey, Christian, check this out. Look at how good his RV does at like 30 parts per million. And, you know, besides the chest pain it gave me, it's just, you know, it's fun to watch. It's just stuff I haven't had in the past, you know. And I, you know, despite the cost, which is a whole nother story, I think I was sort of poo-pooed it and didn't use it that much. But with the, you know, right heart failure we're seeing, it's really pretty commonplace for us now.
Thank you. And I thank all of you in the panel and everybody in the audience. I hope that over time we'll all be familiar with each other, so you guys can jump in and ask your curious questions or put it in the comment, and we'll call on you and draw you out. We really appreciate Dr. Morris, Dr. Tapson, Dr. Amundson, Dr. Sandrock, and everyone who's contributed to this evening. Also to our supporters, as well as CTS staff, Vicki, Phil, and Dave Eubanks. I want to commend everybody behind the scenes. And next week, I know we are kind of waning in our surge. We don't know what February holidays, now that we're back open in our state, Valentine's Day, restaurants, who knows the variant, how this is all going to play out in the next 4 weeks, but we'll keep this going. I think our next session may deal with a little bit of a debrief and lessons learned that we can then start implementing if we are to surge back up. So thank you all for your time. I know we went over, but it's a testament to our speakers tonight that everybody was riveted. So thank you all, and I wish you a good weekend.